So my friends, today we are going to talk about, at last, cholinergic drugs, right? The drugs which produce in our body actions which are normally produced by acetylcholine, right? So we are going to talk about cholinergic drugs. Now, cholinergic drugs are those drugs which increase the cholinergic activity in our body. Now, cholinergic drugs are primarily classified as direct-acting cholinergic drugs, direct-acting cholinergic drugs, and indirect-acting cholinergic drugs. Now, what is the real difference between the direct acting and the indirect acting? Let's suppose this is a cholinergic neuron, right? And this neuron is releasing from here acetylcholine. That's very right. And acetylcholine is going to work on this tissue, this specific tissue, and let's suppose here is cholinergic receptor. Of course, cholinergic receptors may be ion channels or they may be, yes, 7-pass G protein coupled receptors, right? Now, as you know, when acetylcholine is released, of course it will stimulate post-junctional cholinergic receptors as well as pre-junctional cholinergic receptors, but very rapidly it is catabolized, and catabolizing function is done by the enzymes, and these enzymes are called, yes, these enzymes which catabolize the acetylcholine, right? These are called acetylcholinesterases. These enzymes are called acetylcholinesterases. Is that right? Now, these enzymes are very well concentrated at the synaptic membrane, synaptic junctions, especially with the post-synaptic membrane, right? As well as with pre-synaptic membrane. Acetylcholinesterases enzymes are present in very high concentration in association with post-junctional membrane and pre-junctional membrane. Is that right? Now, as you know that as soon as acetylcholine starts its action, very rapidly it is destroyed by acetylcholinesterase enzymes. Having this basic concept, now I will explain what is meant by the direct-acting cholinergic drugs and indirect-acting cholinergic drugs. Direct-acting cholinergic drugs are those drugs, direct-acting cholinergic drugs are those drugs which can actually directly work at the receptors. What are direct-acting cholinergic drugs? Direct-acting cholinergic drugs are those drugs, right, which are structurally or functionally similar to acetylcholine, right? And direct-acting drugs, cholinergic drugs, are those drugs which can bind with cholinergic receptors. Some of them bind with the nicotinic receptors, some other direct-acting bind with the muscarinic receptor. Still there are some others which will bind with the nicotinic and muscarinic both receptors. So what are direct-acting cholinergic drugs? The drugs which directly activate the cholinergic receptors, right? Then we talk about indirect-acting cholinergic drugs. Now, indirect-acting cholinergic drugs must be increasing the cholinergic activity in our body, but not directly acting on the receptors. Indirect cholinergic drugs basically inhibit the action of, yes, they inhibit the action of, what is this? Acetylcholinesterase. Let us suppose there is a drug which can bind here and inactivate the function of, what is this? acetylcholinesterase. And such drugs which can bind with the acetylcholinesterase, right, or even with the butyrylcholinesterase. You know, acetylcholinesterase is at the junctions, right, and butyrylcholinesterase is present in plasma, right. So most of the indirect acting cholinergic drugs are the drugs which bind with the, what is this, acetylcholinesterases and inhibit them. When their action is inhibited, then what will happen? Whatever endogenous acetylcholine is released, it is not destroyed and its life increases, and acetylcholine accumulate at the synapses and its action on the cholinergic receptors increases, right. In this way, indirect acting cholinergic drugs, by inhibiting acetylcholinesterases, enhance the action of endogenous acetylcholine. Am I clear? No question? Now let's go in little detail. Now, what is the different types of direct acting cholinergics? First I will discuss about the direct acting cholinergic drugs in the lecture, and later on we will talk about indirect acting cholinergic drugs. Now direct acting cholinergic drugs, they may be mainly muscarinic drugs which are dominantly stimulating the muscarinic receptors, and other group is nicotinic drugs, direct acting drugs which stimulate the nicotinic receptors preferably. Now in the muscarinic drugs which bind with the muscarinic cholinergic receptors and activate them, it means these drugs has affinity with the muscarinic receptor as well as they have a capability to intrinsically stimulate muscarinic receptors, because if a drug binds with the receptor but does not stimulate, then it is antagonist. But if a drug binds with the receptor and stimulate, then it is agonist. So of course, now we are going to talk about muscarinic cholinergic drugs. It means these are muscarinic agonists. It means this group of drug can bind with the muscarinic receptors and stimulate them. Am I clear? Right. Now in this case, there are two types. Some of the drugs are cholines, choline esters, and others are derived from the plants, that is, they are alkaloids. Now, choline esters. Do you know us? Can you tell me a single choline ester drug? Drug in which choline is present in esterified form? Please tell me acetylcholine. Acetylcholine is an ester of choline, right? Even though it is not used as a drug, I will tell you later why, but at least you should tell me acetylcholine, which is a compound which can stimulate muscarinic, of course, but it can also stimulate nicotinic, right? Acetylcholine is not, you can say, selective to muscarinic, right? Now acetylcholine. Then there are some other molecules which are produced by modification of acetylcholine, or the molecules which are structurally similar to acetylcholine, but there are some significant differences. For example, there is a drug called methacholine. There is a methyl group here, methacholine. Then there is carbachol. In this case, in place of acetate, there is carbamate. You know, acetylcholine has acetate and choline. This has carbamate and choline, carbachol. Is that right? Then there is another compound that is called bithanicol. In bithanicol, again, actually with the choline there are carbamates, not acetate, right? Now, botanical also has methyl group addition. If you don't want to remember this, no problem, but you have to remember this thing that methylcholine, carbachol and botanical, they are basically molecules which are able to stimulate the muscarinic receptors, right, preferably. Especially about botanical, it has main action on muscarinic, but it does have some little action on nicotinic also. But others are mainly on the muscarinic. Carbachol is mainly on muscarinic. Sorry, let's do a little correction. Botanical is mainly muscarinic. Carbachol is muscarinic with little nicotinic. Methylcholine is mainly muscarinic. Acetylcholine is muscarinic plus nicotinic. There is no doubt about it. Is that right? Then there are alkaloids. Can you tell me alkaloids? Yes. Can you tell me some alkaloids which are derived from the plant and which can stimulate the muscarinic receptors? Right? At least tell me muscarine. Muscarine is, why muscarinic receptors are called muscarinic receptors? Because they can be stimulated by muscarine, and muscarine is derived from plants, right? Or mushroom. So muscarine. Muscarine. Any other drug which is derived from the plant and it can stimulate the muscarinic receptor? Yes, that drug is very, very important. One of my friends is again and again saying cocaine. Right? Of course we'll study cocaine, but not in this lecture. Yes. Pylocarbine. Have you heard of? Pylocarbine. Right? So these are direct acting, dominantly muscarinic drugs in which methylcholine, carbachol, botanical, they are choline esters, and muscarine and pylocarbine, they are the alkaloids. Is that right? We will discuss them in detail now, right? And nicotinic drugs, we will study them with the CNS stimulants. And indirect acting cholinergic drugs, we will discuss after discussing these drugs, right? So let's go into detail of these drugs. Because you have a very good foundation about cholinergic system, now this lecture is going to be dangerously easy. Too much easy. Let's start one by one. First of all, we talk about a drug called acetylcholine. Now, first of all, what I want to say, acetylcholine is usually not used pharmacologically. Why? Okay, there's a one answer. Someone is saying we don't use acetylcholine as a drug because we already have it. Okay, we have many other things, but still we may take it as a drug also. Yes, no, it's not the right answer. Anyone can tell me that when we want to stimulate cholinergic system in our body for some therapeutic purpose, usually we don't use acetylcholine. Why? Yes, my friend. Question is very simple, that acetylcholine, you know so well about it, but when we need to increase cholinergic activity in our body, usually we don't use acetylcholine. Why? Yes. Okay, but the real reason is that acetylcholine has a very, very short half-life. It's measured in seconds. Is that right? Why? Because when acetylcholine is injected, it will be very, very rapidly destroyed by butyrylcholinesterases which are present in plasma. And you know other names for butyrylcholinesterases? Non-specific cholinesterases, pseudocholinesterases, right? So butyrylcholinesterases or the pseudocholinesterases or non-specific cholinesterases, these are one and the same enzyme having three different names, and they are abundantly present in your circulation of plasma. And because they are present abundantly, right, and they destroy the pharmacologically introduced acetylcholine rapidly, so acetylcholine cannot, and of course, not only acetylcholine is destroyed by pseudocholinesterases, whatever acetylcholine you push in your body, that will be also destroyed by the acetylcholinesterases, right? Because of this reason, acetylcholine has a very, very short life. If you inject it, it will last in your blood from 5 to 30 seconds only. So this is one reason that usually when we want to use a cholinergic drug therapeutically, we want a longer action. Is that right? So this is one reason, that very short half-life, right? It's very rapidly destroyed in our body, right? Number 2, acetylcholine has diffuse action. Acetylcholine, if you really inject it in heavy doses, if it reaches to its target receptors, it will produce multiple diffuse activities in the body. And usually, pharmacologically, we require a drug which will hit a specific action in our body, right? So second reason is because acetylcholine work on all its nicotinic and muscarinic receptors, it activates the whole cholinergic system in our body non-specifically, diffusely, and due to that reason, it does not have any important pharmacological application. This is diffuse because it produces diffuse activation of cholinergic system, activation of nicotinic and muscarinic receptors. So you can understand it can go to the central nervous system, stimulate nicotinic and muscarinic receptors in central nervous system. But here I said something wrong. It does not go to central nervous system. The reason being it is highly charged compound. It is highly polar compound and it cannot cross, cannot cross biological membranes including the blood-brain barrier, right? It cannot cross biological membranes. You know biological membranes like blood-brain barrier, or there is placental barrier, or if drug is taken orally, it has to absorb from GIT mucosal barrier. These barriers are made of cells and their membranes, which are lipid bilayers. And drugs which are highly charged, they cannot effectively cross the different biological barriers, including the acetylcholine. So acetylcholine has these multiple problems. Due to that reason, it cannot be used as pharmacological agent because it is destroyed very rapidly in our body, right? It has very short duration of action. Secondly, if really you get it in the body in high concentration, it will produce diffuse activation of nicotinic and muscarinic receptor all over the body. Cholinergic activity will start. It's not something to be very happy about that, and it cannot cross biological membranes effectively, right? But just speaking hypothetically, right? Let's do a little practice what we learned in previous lectures. If acetylcholine is given in heavy amount and transiently it activates the cholinergic system in all over body, it stimulates the cholinergic receptors all over the body, what will be the results?
Sweating.
Number 1, which site will be activated? What are the sites of the cholinergic receptors? Cholinergic receptors. Basically, cholinergic receptors, which one? They are present in four, we can classify in so many ways. One way is they are present in central nervous system. Secondly, they are present on ganglia. It means, and which ganglia? Sympathetic or parasympathetic? Both. So it means if acetylcholine will go and stimulate all your parasympathetic ganglia and sympathetic ganglia, there will be such a diffuse action and non-selective action, right? Thirdly, cholinergic receptors, especially muscarinic receptors, they are present at neuroeffector site of sites of postganglionic, most of the postganglionic parasympathetic fibers. So all the tissues where parasympathetic postganglionic fibers are going, they are having cholinergic receptors, muscarinic. All those tissues will be stimulated. Do you think it's a limited action or very diffuse? It's very diffuse. And in the end, you don't forget, cholinergic receptors are also present in neuromuscular junctions. So do you think that if you give a drug like acetylcholine, okay, if it is given in general circulation, it will not cross blood-brain barrier, but at least it will stimulate the ganglia. It will stimulate all the neuroeffector sites where parasympathetic postganglionic fibers are giving cholinergic activation and also neuromuscular junctions. Do you think you are getting some non-specific action on the body or specific? Non-specific. Due to all these reasons, this is not a very good drug. Generally speaking, what will happen to someone who has massive cholinergic stimulation? You know already. There will be heavy sweating, there will be lacrimation, pupil constriction, ciliarus, spasticity, yes, nasal secretions, broncho constriction and tracheobronchial secretions, then lot of salivatory action, yes, all GIT secretions will be more, GIT motility will increase, defecation will occur, and you come to the heart, what will happen? Bradycardia, and if acetylcholine goes to the blood, it binds with the M3 receptors on the endothelial cell, massive amount of nitric oxide is released. Excellent. All of you know that massive vasodilation and hypotension, and then you don't forget, along with the defecation, there will be also urination because detrusor will be stimulated. So do you think it's some very good action that you give someone really a good injection of acetylcholine and he is sweating and he is lacrimating and he is salivating and he is urinating and he is defecating and he is dying with cardiovascular collapse with having meiotic pupils? Do you think it's something great? So now you understand it, why acetylcholine is not a great drug. Is that right? Now we go to some of its related compound. As I told you, there is bethanechol, carbachol, methacholine, right? Let's talk about those drugs. First of all, I will talk about acetylcholine related drugs which are bethanechol. Bethanechol. Now, bethanechol has relatively stronger action on muscarinic receptors, right? One of the best way to remember bethanechol is, yes, and its action is, and its uses. You can remember its action and uses by a very simple thing. Yes, Beth is a boy's name or girl name? You are sure? Okay, the other things are not good. Beth activates bowels and bladder. Bowels and bladder. Even though girls like to activate other things, but here the Beth is activating bowels and bladder. I mean gastrointestinal system and urinary bladder. Is it a good news? Okay, it's not good news for Beth or the person who is going to have Beth, but for bethanechol, for the doctor, it's a good drug. It's a cholinergic drug which strongly stimulates muscarinic receptors on the GIT and urinary bladder. So, if you want to activate in a patient gastrointestinal system or you want to activate his urinary bladder, bethanechol is a very good drug. Is that right? It does not have any significant nicotinic action, right? In bethanechol, the acetate with the choline, there is acetate in acetylcholine. But in bethanechol, acetate has been replaced by carbamate. In bethanechol, what happened? That acetate is replaced by carbamate. Now, you remember there was a drug called, enzyme which is called acetylcholinesterase. Now this enzyme which is called acetylcholinesterase, is that right? Now this enzyme very effectively destroys acetylcholine, right? But actually, this cannot so effectively destroy the bothanicol. The reason being, bothanicol is a slightly different molecule where acetate has been replaced by carbamate, and this acetylcholinesterase is an enzyme which breaks down the ester link between the acetate and choline. This enzyme is not very effective in breaking down the ester link between choline and carbamate. So, this drug will be destroyed slowly by acetylcholinesterases and butyrylcholinesterases. So, this drug will have short duration of action like acetylcholine, or this will have a longer duration of action? Longer duration of action. You understand it? In bothanicol, you can say it's a modified acetylcholine in which acetate has been replaced by carbamate, and this change in the molecule does not allow the cholinesterases to destroy this molecule very effectively. So due to that reason, right, this drug is destroyed relatively slowly, so it has a longer duration of action. As acetylcholine has 5 to 10 or 20 seconds, but this has duration of action usually more than 60 minutes or 1 hour. Is that right? It's a significant thing that something which is destroyed in 10 seconds, now it can stay for 60 minutes or 1 hour. Is that right? Now, secondly, not only here in this drug, bothanicol, not only acetate is replaced by carbamate, but there is also addition of methyl group. There is addition of methyl group. And when methyl group is added to this drug, right, this molecule does not bind with nicotinic receptor. So that's a good news or bad news? It's a good news because now action of this drug become little bit specific. It become more selective. Are you getting it? We really like the drugs which can act for longer duration in some situations, and we like the drug which will hit exactly those receptors where we really want to have an action. So acetylcholine and bothanicol, how they are different, that in bothanicol acetate is replaced by carbamate and there is the addition of methyl group. So duration of action of this drug become longer and its capability to bind with the nicotinic receptor is reduced. So it's mainly having action on muscarinic receptors, and specifically it loves to activate muscarinic receptors on gastrointestinal system and urinary bladder. So you can say that BATH activates bowel and bladder. How you remember? B for bath, B for bowel, B for bladder. Is that right? There's no other popular drug in this group. We start with B, right? So B for bath, bothanicol, B for bowels, B for bladder, right? So next time someone asks you, bothanicol, what's its function? It activates bowel and bladder. Is that right? Any question up to this? Now what should be its uses? Very easy to understand. It should be used, this drug can be used when bladder is not contracting properly or when gastrointestinal system is not contracting properly. That's so simple. You don't need to be genius to answer this. This drug will be used when there is a hypoactive GIT and there is a hypoactive urinary bladder. Is that right? But make it sure there should not be any obstruction. Before I tell you indication, I should tell you contraindication. If someone has a urinary retention, right? Look, if there is a poor man having urinary retention because there is a stone here, or there is malignancy here, or there is some stricture here, there is some obstruction to outflow. Do you think we should give a drug like bothanicol? Not at all. If there is obstruction to urine outflow, right? Don't give bothanicol. You know why? Bladder will strongly contract and patient will have severe pain, but if there is a fixed stone or some tumor here, right? Patient will only have very severe pain and he will remember your face. This was the doctor who did something and then my trouble was aggravated. If someone has urinary retention to benign prostatic hypertrophy, BPH, do you think you should give Methylcholine? No. We will give drugs like Methylcholine to activate the urinary bladder when the retention of urine is without any outlet obstruction. When retention of the urine is because bladder is not contracting well, right? So we can say that this drug can be used to activate the urinary bladder in cases of non-obstructive urinary retention. What kind of urinary retention? Non-obstructive urinary retention. Is that right? Now, what could be these conditions? This may be postoperative urinary retention. Classical example, not due to stone. This may be postoperative urinary retention. Sometimes after the operation, patient cannot pass the urine and urine is retained. Probably his autonomic nervous system is not working well. Is that right? Or ganglia are not working well in the pelvic organs or in the abdominal viscera. And a patient is unable to pass the urine, but due to retained urine, he feels strong discomfort, right? So in case of postoperative urinary retention, where there is no outflow obstruction, we can use this drug. Then any other condition? Postpartum urinary retention. What is postpartum? When a woman has delivered a baby, usually women deliver the baby, and some of them, they develop urinary retention after delivering the baby, right? In that case, we call it postpartum urinary retention. Again, there should not be any outflow obstruction, and then you can activate the bladder by giving an injection, subcutaneous injection of Methylcholine, right? So Bethy moves the bowel and bladder. That's so easy. Is that right? So postoperative urinary retention or postpartum urinary retention, right? Then in some other chronic hypotonic or myogenic or neurogenic bladders, or some cases in which there is chronic hypotonic in different diseases, urinary bladder detrusor become hypotonic, it does not contract well, or myogenic, that muscle is not, detrusor is not contracting, or neurogenic, right, bladder. So when there is hypotonic bladder or myogenic or neurogenic bladder, right, in these conditions urinary bladder does not contract well and usually urine is retained, and retention of urine is dangerous. It predisposes the person for urinary tract infections, right? So rather than keeping a catheter inside, one of the ways that you use Methylcholine to activate the urinary bladder. Am I clear to all of you?
Yes.
Right. Now let's talk about when we need to activate the bowels, when we want to activate the GIT pharmacologically. Yes. Again, when there is postoperative adynamic ileus. You know what is ileus? Postoperative adynamic ileus. Ileus means paralysis of GIT. After abdominal operations, many times GIT is not, after the operation it's not mobile, and if it takes very long time to recover its motility, we can activate the GIT by Methylcholine. Am I clear? So, or those cases which we call it atonic, yes, stomach, atonic stomach, or we call this condition gastroparesis. When someone has a stomach which does not contract well, or whatever he eats, it is well retained in the stomach and it does not push properly to the duodenum, you can activate the stomach motor function or enhance or potentiate the stomach motor function by Methylcholine. Is that right? Or there is ileus. Ileus means paralysis of GIT. Ileus due to any toxic reason. Ileus due to any toxic reason, toxic cause, right? We can activate the GIT, but there are a few things which are very important. Before activating the GIT, you must know that there is not any obstruction in the GIT, because if there is some obstruction in the GIT, for example intussusception, and you give botanicol, patient will be in trouble. Already there is a block in GIT and very strong peristalsis come, maybe GIT perforate, rupture, right? So make it sure, as I told you, when there is urinary retention, you want to activate the bladder, you should be sure there should be no obstruction. In the same way, when you are activating the GIT, you have to be careful that GIT is not having any obstruction, right? Am I clear? There should not be any obstruction. Then another condition in which this drug can be used, that is called congenital megacolon. Congenital megacolon. What is congenital megacolon? And what's the underlying problem? Yes. Who is going to tell me? What is congenital megacolon? What really happens, megacolon look, this is colon, of course this is cecum, and here is your ileum coming and your friend appendix. Okay, now you know that this part of the colon, that is supplied by vagus, and last part of the colon, this is supplied by nervi arigentes or pelvic parasympathetic nerves. Now sometimes it happens that ganglia are absent from a short segment of colon. This is a congenital defect. That neuronal ganglia, you know, Auerbach plexus and Meissner's plexus, these ganglion do not develop in small segment of the colon. Maybe the neurological ganglion system from this side and this side, where it was supposed to fuse, they remain short of fusion. So there is a ganglionic segment. In the GIT there is a ganglionic segment, a segment in the colon without any ganglion. So what really happens, that this part of the colon contract, but when it brings the material here, can it push forward? No. So in a way, this will become a dynamic part of colon. It does not propel and have motility properly, right? So in a way, the proximal part of the colon become mega, enlarged, right? Because there is an obstruction at this point. This is not a physical obstruction. This is problem that colon is unable to create motility in a short segment. So whatever you can say content of GIT are coming, they are retained proximal to that point, and we say that colon is becoming very large, megacolon, and this problem may be present congenitally. We call it congenital megacolon. Some of these cases with congenital megacolon can also be managed by administration of botanicol. Is that right? No problem here? Okay. Having said all these things, now let's talk about what could be the side effects of botanicol. Who will tell me? Again, let's repeat. Botanicol is having longer half-life as compared to acetylcholine because it is replaced its acetate with carbamates, and it does not bind and stimulate the nicotinic receptors because it is methylated also. Botanicol, the Beth activate bowels and bladder, very messy business, right? So all those conditions where we need to activate the urinary bladder or gastrointestinal musculature, we can use botanicol, but we should make it sure there is no obstruction to forward movement. Then I was talking about what could be the side effects. I think by this time you must be able to tell me. Side effects will be all the side effects which are produced by generalized cholinergic stimulation. Generalized cholinergic stimulation, right? So what will be this? It's so easy to understand. Sweating will be there, salivation will be there, lacrimation can be there, abdominal secretions and peristalsis and abdominal cramps may be there. Yes, urgency, or you can say rush to urinate, right? Then there may be flushing and hypotension. Flushing is what? The cutaneous blood vessels dilate. Don't confuse it with blushing. Blushing is a different thing when you blush. You know, that some part of the skin under emotional state, it blush on, right? But these days when girls don't blush, what they do? They put the blush on, right? But don't confuse the blushing with flushing. Flushing is generalized cutaneous vasodilation. So what will be the actions? Again, generalized action of cholinergic, that this drug, if given little more, there will be sweating. Let's start from the top. There will be sweating, meiosis with spasticity of ciliaris and difficulty to focus the eyes, so blurred vision. Then with that there can be flushing, then there can be, yes, salivation, lacrimation, salivation come down, bronchoconstriction and tightness in the chest, and then bradycardia and hypertension related complications can come, and gastrointestinal secretions are increased along with motility and cramps, abdominal cramps, and then in very severe cases may be defecation and urinary. Right. Now these are the side, of course, these are the generalized side effect produced by generalized cholinergic stimulation. Then there are some specific contraindication to the use of botanical. There are some conditions we should not use botanical because it's cholinergic stimulant. For example, in peptic ulcer patient. Why? Because muscarinic stimulation can increase the secretion of gastric acid, right? So it is contraindicated in peptic ulcer disease. Okay, it is also contraindicated in COPDs, chronic obstructive pulmonary diseases. Why? Because it produces bronchoconstriction. So already they are having problem that people who have chronic obstructive pulmonary diseases, at the top you give this drug, okay, you will move the bowel but you will stop the oxygen. Is that right? So it's contraindicated. Then patient with the ischemic heart disease with coronary problem. If someone has coronary atherosclerosis, a part of myocardium is getting less blood flow. At the top you give this drug and hypotension, less pressure and less blood going into coronary, further drop in the ischemic area blood flow, and that may precipitate myocardial infarction. Is that right? Even cholinergic action in the patient with in the atria, it may precipitate tachyarrhythmias, right? Because it reduces the, what is that, effective refractory period in the atrium, and it can precipitate tachyarrhythmias. Then this is also contraindicated in hyperthyroidism. The answer is simple in hyperthyroidism. Why it is contraindicated in hyperthyroidism? Because patient with hyperthyroidism, many of them do have atrial tachycardia or atrial flutter already. And when you give muscarinic stimulant, right, they may go to atrial fibrillation. Am I clear? Again, the cause is because muscarinic drugs can reduce the refractory period, effective refractory period in atrial tissue. Right? Okay, the last contraindication which I am going to tell you is Parkinson's disease. Parkinson's disease. Why? In Parkinson's disease, normally what is happening? Balance between acetylcholine and dopamine is disturbed. You know, in the central nervous system, dopaminergic activity and cholinergic activity, they are imbalanced. What really happens in Parkinson's disease, that nigrostriatal dopaminergic neurons are degenerated. So dopamine activity become less, and relative to dopamine, cholinergic activity become more. And so in Parkinson's disease, reduced dopaminergic activity produces hypokinesia. And in Parkinson's disease, excessive cholinergic activity produces tremors. And at the top, if such patient is given cholinergic drugs, you will exacerbate the tremors. Am I clear? Okay. Having said everything about Methylcholine, now we go to the next drug, and next drug is carbachol. Again in carbachol, there is also acetate replaced by carbamate, but there is no methylation. And now you can understand. It will stimulate muscarinic as well as to some degree nicotinic. Are you understanding me? Yeah. Right? So both of them have longer duration of action, but here there are carbamates here, carbamates here. There was methylation here, but no methylation here. Due to this reason, it is able to stimulate muscarinic plus nicotinic action. So do you think it will be very useful drug? No. So these days, it is not commonly used systemically. Carbachol is not commonly used systemically because it can intensely stimulate the generalized stimulation of the ganglia, right? And initially it stimulates the, yes, it stimulates the ganglia and then ganglia go into depression. So first stimulate and then inhibit, right? In the same way, it stimulates neuromuscular junctions and then inhibit, right? So due to this reason, it has a strong stimulation to cardiovascular system and then depression. Strong stimulation to GIT and then depression. So do you think such kind of drug is very good to use systemically? No. So thank God we are not using systemically, so you don't need to remember much about it. The only important use of this drug is in the eyes, right? We use carbachol for the producing meiosis and also for contraction of ciliaris muscle. Actually, by these actions, it helps us to lower the intraocular pressure in patient with glaucoma. Now, how the meiosis and how the ciliaris contraction reduces intraocular pressure, that I will explain later when I will explain the Pylocarbine, right? I will tell you exact mechanism. For a while you just trust me that by producing strong contraction of the sphincter pupillae and contraction of the ciliaris, we reduce the intraocular pressure. These days in glaucoma, to reduce the intraocular pressure, Pylocarbine is a preferred drug as compared to carbachol. So this is used in patient of glaucoma only when Pylocarbine is ineffective. So again, you don't need to know much about this drug, right? This is enough to know that it is a meiotic agent, right? It can be used to reduce the intraocular pressure in glaucoma, but usually it is not the first line drug. Then we come to another drug, and that is called Methylcholine. That is Methylcholine. And again, now Methylcholine is not systemically used, it has one common use. You know what is the use of Methylcholine these days? Those patients where we suspect that these patients have hyperreactive bronchial system. There is a term used, bronchial hyperreactivity. Bronchial hyperreactivity means that if bronchial tree is little bit irritated, it will intensely produce bronchospasticity or constriction, right? So if we have to diagnose a person with asthma, or we are not sure he is having asthma or not, then we check his bronchial hyperreactivity. We give little inhalation of Methylcholine. We give very little Methylcholine by inhalation, which will produce very little bronchoconstriction in a normal person, but that amount of Methylcholine will produce relatively strong bronchoconstriction in a patient with hyperreactive bronchial tree. Am I clear? Of course, before doing this test, you should have bronchodilators with you. Am I clear? Right? So, but methacholine is having one important use these days, that it is given by inhalation, right, to challenge the bronchial tree to check for the hyperreactive bronchial smooth muscles. Is that right? And after the giving this inhalation, we check the respiratory function test, and we see that there is a little drop in the airflow, right, or there is a big drop in airflow. So this is the only use in methacholine. Now let's go back. Botanicol, Beth activate bowel and bladder. Very good. So easy. Carbachol can activate many things, but we don't want it, right? We just put in the eyes only when Pylocarbine and other first line drugs are not working well, right? And they can be used, Carbachol can be used in glaucoma as a second line or maybe last line drug. Methacholine, again there's only one use. It stimulates the muscarinic receptors. We give it by inhalation to the bronchial tree to stimulate the muscarinic receptors on smooth muscle to look for the bronchial hyperreactivity. Am I clear? And now we come to the last drug in this group, that is Pylocarbine. That is what I would really love to explain a little bit more. Pylocarbine. This is important drug to know, right? Now Pylocarbine, again it's a muscarinic drug, is that right? It's a tertiary amine, right? It is tertiary amine and it is stable with acetylcholinesterases. Stable means it is not easily destroyed by acetylcholinesterases. So its half-life is long, right, as compared to acetylcholine, significantly long. Pylocarbine is basically an alkaloid derived from the plants, right, and it is stable to the action of acetylcholinesterases. Now, what are the important uses of acetylcholine, right? Number one, there are ophthalmic uses. Okay, let me tell you, it is used in patients with glaucoma. In patients with glaucoma, this is used topically. Topically mean what? Right? It is applied directly to the cornea and conjunctival sac. We put it there. Right? From there, Pylocarbine will be absorbed and it will act on the muscarinic receptors on the sphincter pupillae, and it will also act on muscarinic receptors on ciliaris muscle. Right? And it helped to improve the it helped to reduce the intraocular pressure. Now exactly how it works, let me tell you. First, I will tell you how the aqueous humor normal circulation is present in the eyeball. Let's suppose here is your eyeball and now a very important thing which you must know first of all is, I will put the lens here. This is the lens. Here is your what is it? Iris, right? And here is what? Pupil. This is the pupil, right? There is iris here. Now this is cornea. This is sclera. Am I right? This is sclera. Here is cornea. Now, actually, and of course, here is your suspensory ciliary body I must produce. And here is also ciliary body with ciliaris muscle. Ciliaris muscle is fixed over here. Right? And of course, you know that there are zonular clear? Now, What is the circulation of aqueous humor? I should enlarge this area to show you in the detail, and this area also. Now, aqueous humor is produced by ciliary epithelium from here, right? Secreted by that. It moves between the lens and iris, on the back of the iris, and then from here it moves into anterior chamber through the pupil. Aqueous humor is produced by, of course you must be knowing, here is something which is called vitreous body. This is full of, right? Now, aqueous humor is produced by what is this? Ciliary body having ciliary special epithelium. It is secreting the aqueous humor. It is moving through the posterior chamber. Posterior chamber is behind the iris, and anterior chamber is in front of iris, and a posterior and anterior chamber communicate through what is this? Pupil. So aqueous humor is produced in the posterior chamber or secreted in the posterior chamber. It moves towards the pupil, and through the pupil it goes anteriorly into anterior chamber, and in the anterior chamber it moves to the corneo-scleral junction. This is the cornea and this is sclera, and this is the corneo-scleral junction. And here, now this is the point to understand, that here there are at corneo-scleral junction there are special type of trabeculi here, connective tissue network. We call it trabecular meshworm network, right? And here there is a very special vein which is called canal of Schlemm, and here also what is this called? Canal of Schlemm. Now, aqueous humor secreted by ciliary surface comes into posterior chamber, through the pupil it comes into anterior chamber, and while washing on the back of the cornea it comes down and on up, or you can say from the center it moves to the periphery at corneo-scleral junction. It moves through this trabecular network. What is this? Trabecular network, and through that it drains into canal of Schlemm. So it's coming like this. From here it will percolate and then come into canal of Schlemm, which is special venous drainage system here, and eventually then it will drain into other veins and go to eventually to the systemic veins. Is that right? This is the circulatory system of the aqueous humor. Now what happened? When aqueous humor, its pressure in the intraocular system is very high, we say there is glaucoma, right? Now, what are the different types of glaucoma? There are many types, but I will explain only now closed angle glaucoma and open angle glaucoma. First, you want me to explain closed angle glaucoma or open angle glaucoma? Yes, tell me what you want first. Open angle or closed angle? Closed angle. Okay, let's have a little break and then we will continue. Right, so we were talking about glaucoma. I was saying that there are two types of glaucoma. There is open angle glaucoma and open angle glaucoma and closed angle or narrow angle. It's same thing. Narrow angle or closed angle glaucoma. Now, first I will explain the open angle glaucoma. In open angle, first of all, what is angle? First of all, we should know which angle we are talking about. It is narrow or wide, or actually narrow angle is between the corneal and iris. Is that right? Now, or corneo-scleral junction is having this angle, and at this angle there is a, let me tell you, this angle should be considered like this and like this. Is that right? In this angle, what is this? Trabecular meshwork, a network of connective tissue and collagen system. Is that right? Now, this is the angle through which normally aqueous humor filter and reach to the canal of Schlemm and then to be drained. Is it clear? Now what happens? Sometimes doctor found that in some patient angle is open, they can see the trabecular meshwork but pressure is high. later on they came to know in these people, actually within this trabecular meshwork, right, there is narrowing. Angle is not narrow, but this filtering system is having some resistance to flow. Why? Maybe with the aging, as our age increases, our arteries become hardened or softened. Our arteries become soft or hard? Hard. In the same way, with that age, there is some change in the connective tissue here, right? And it becomes difficult for aqueous humor to move through this trabecular meshwork and drain properly. But when you look at the angle is open. We also call it open angle glaucoma or wide angle glaucoma. Now, initially doctors could not understand, but now they know that there is a resistance within this meshwork. In this case, if we use a drug which will contract ciliaris, what will happen? When ciliaris will contract, it will pull the angle posteriorly. When ciliaris muscle will contract, it will pull the angle posteriorly. And when it will pull the angle posteriorly, what will happen? That there will be traction on this network and it will open. Am I clear? Jesus, you understand it? Yes. What is happening? That we are using a drug here which is going to lead to contraction of, what is this? Ciliaris. And when ciliaris contract, it has a traction or pull on the trabecular meshwork and slightly open it, right? And that will help the better drainage of aqueous humor and intraocular pressure will be going down. Am I clear? So this is how it works in open angle glaucoma. But Pylocarbine is also very well known for the use in acute cases of narrow angle glaucoma. Now first of all, I must tell you what is narrow angle. Then I will tell you what is narrow angle glaucoma. And then I will tell you how Pylocarbine works. Actually, narrow angle means in some people, right, actually anterior chamber is shallow. In some people, interior chamber is shallow. It is not deep. This is less. And some people have relatively smaller eyeballs or congenital, or you can say that developmentally their eyeballs are designed like this, that distance between the iris and the cornea is very little. So they are having relatively narrow angles. Now, these people who have a narrow angle, they have one problem. Some of them eventually develop a problem that when pupil will dilate, they develop glaucoma. How? Let us suppose if pupil dilate, then it means the dilator pupillae are opening the pupil and pupil will move from this place to the periphery. Rather than iris is like this, when pupil will dilate, configuration of iris will be changed. Now you see, pupil which was previously like this, it is large. But when pupillar dilation is there, then actually iris goes away from the center and moves to the periphery, and root of the iris or base of the iris become broad. Are you understanding? You are not understanding. Okay, let me tell you here, come. Look, this is the iris, right? Now this is the base of iris, right? And here is what? Pupil. Is that right? Now, if we produce pupillar dilation, I'm changing it, then this will, of course, this point will not change. This point will go outward, right? When it will go up outward, what will happen? That this will be more broadened. This will also come here and this will be more broadened. Are you understanding it? So what really happens that when there is pupillodilation, right, iris moves to the periphery and root of the iris or base of the iris become accumulated at what point? At what point it become accumulated? Near the corneoscleral junction. And this angle will become wide or it will become narrow? It will become narrow. So what happens when if already someone has relatively narrow angle, at the top there is pupillodilation, then root of the iris will accumulate at the angle and make the angle narrow. This is one problem. So due to this reason, these people who has a tendency to develop narrow angle glaucoma, especially in early time, they develop this problem when they go to at night or in the rainy season or when they go to cinemas, because when pupil dilate significantly for longer time, root of the iris accumulate at the periphery and hinder the drainage. Another problem which occurs in these patients is that intraocular pressure becomes very high. Of course, when drainage is blocked due to narrow angle, intraocular pressure will become low or high? High. When it becomes very high, then what happens that aqueous humor is unable to move forward because there is a block here. It cannot drain. So aqueous humor accumulates here in the posterior chamber, and then this aqueous humor push the iris forward. Are you understanding? What aqueous humor is doing when it is accumulating here too much under high pressure, it pushes the iris interiorly. That further closes the angle. And that closes the angle, and so much pressure become high that there is very severe pain here. So this is a case where there is very severe pain and even edema of the cornea develops due to high pressure. Right? Eye become red. So red eye with very high pressure, it may be a case of acute case of narrow angle glaucoma. You are understanding? So what are the narrow angle glaucoma? In which when you look there, you find the angle is really narrow. Is that right? Now in this case, Pylocarbine is wonderful. In emergency cases, we put repeatedly drops of Pylocarbine. What Pylocarbine will do here? It will lead to, what is this? Sphincter pupillae. It will lead to the contraction of sphincter pupillae, and intense contraction will pull the root of, what is this? Iris away from the corner. So when there will be pupilloconstriction, iris will be pulled centrally, right? And there will be less accumulation of root of iris or base of iris at the angle, and angle will become opened, and again drainage will become better. Am I clear? Or do I need to repeat it again? Everyone is clear about it. So we can say Pylocarbine or any drug which is meiotic as well as producing contraction of ciliaris, they can be used in glaucoma cases. In case of open angle glaucoma, this angle is open. Resistance is within the trabecular meshwork. But when ciliaris contract, it has a traction or pull on the network and open it and facilitate the, what is that? Drainage of the aqueous humor. But in narrow angle glaucoma or closed angle glaucoma, physically this angle is narrow, right? Either eyes are designed with smaller anterior chamber, or there is pupillodilation and root of base of the iris is accumulated at the angle and at the top. When pressure become high, then pressure in the posterior chamber push the iris interiorly. All these things combined make the angle very narrow. Here if you give the drugs which are strongly meiotic or they produce strong stimulation of constrictor pupillae, then constrictor pupillae will lift the iris away from the angles, and angles will be opened. Is that right? So this is the use of Pylocarbine in patients with glaucoma. Then another use of Pylocarbine is, Pylocarbine can stimulate very strongly your secretions. It really piles on sweat, tears and saliva. Pylocarbine piles on, it is not other piles which is a disease. Piles on, yes, sweat, tears and saliva. Sometimes it's so powerful, sweat glands are so sensitive to Pylocarbine that if you give one shot of Pylocarbine, you may have 2 to 3 liters of sweating. Diaphoresis, right? But what is really important right now is that to understand that pilocarpine has one more use. When we want to stimulate saliva secretion and tear secretion, there is a disease, a condition which is called xerostomia, dry mouth. Don't tell me romantic ways to make the mouth wet. We can do it pharmacologically also, right? Xerostomia, when there is dry mouth. Dry mouth can result due to head and neck irradiation. If someone unfortunately has a tumor of head and neck and he has been irradiated, maybe that will destroy some of the parenchyma of the parotid glands and other salivary glands. So when saliva is less, your mouth is all the time dry. And do you think having a very dry mouth is a very good feeling? No. So how much water the person can drink just to keep his mouth wet? Mouth may not be wet by drinking so much water, but maybe bed will be wet, right? So one of the treatment is we give pilocarpine. And these days we use pilocarpine spray in the mouth or tablets, right? They can stimulate the salivary secretion if there is some residual what? Residual gland left there, right? Another condition where we use this is Sjogren syndrome. This is a disease, autoimmune disease, more commonly in females, where autoimmune process destroy the salivary glands and lacrimal glands. You can imagine these females. They have dry eyes and dry mouth, right? In this syndrome. And for these patients, also we can give pilocarpine or another new drug which is longer lasting duration of action, that is Acetylcholine. Another drug is Acetylcholine. Acetylcholine, this is also a muscarinic drug with longer action, and it is also stimulate the saliva production. Is that right? So pilocarpine is an alkaloid derived from the plant having strong muscarinic action, right? You know, whatever the muscarinic actions can be produced by pilocarpine if it is given systemically. Usually we don't use pilocarpine systemically. Major uses are two. Number one in glaucoma and number two in xerostomia. And any other question you have? Yes. Okay, another condition, some other ophthalmological conditions, we also use pilocarpine. You know, if someone has severe pupillodilation or mydriasis due to atropine, for example, due to some reason you put atropine in someone's eye, right, and then you want to reverse the mydriasis, you will put pilocarpine. So another use is when you want to reverse the atropine induced what? Mydriasis, you can use pilocarpine. You can use pilocarpine. Then pilocarpine is also used along with the mydriatic drug when there are adhesions between iris and the lens. This is the lens, and if there are some adhesions between iris and the lens, in some inflammatory condition of the eyes, right? Adhesions may develop between the iris and the lens. Sometimes to break these adhesions, we alternatively give pupilloconstrictor and dilator, right? We give pupillodilator and try to stretch it outward, and then give pupilloconstrictor, pull it inward. So repeatedly alternate it, eventually these adhesions may break. So another use of pilocarpine is the alternative use of pilocarpine with mydriatic drugs to break the adhesions between the iris and the lens. Is that right? Do you have any question? No. Let me check what you have learned today. We were talking about cholinergic drugs. We have mainly discussed direct-acting cholinergic drugs. Indirect-acting drugs we will discuss in next lecture, right? In direct-acting cholinergic drugs, I said acetylcholine is not commonly used as a drug, right? Why? Number one, it has a short duration of action. It is rapidly destroyed by cholinesterases. Number two, It is a diffuse action all over the body, no selective specific actions, right? Then I will talk about Bethanycol. Bethanycol and Methylcholine and Carbachol and Pylocarbine, all of them have longer duration of action as compared to Acetylcholine. Now, Bethanycol, what are its most important two uses? Bowel movement and bladder movement. That's very good. But in cases of obstruction, if there's outflow obstruction to bladder, will you use Bethanycol? No. Very good. Then we come to Carbachol. Carbachol has muscarinic as well as some nicotinic actions. We don't use it commonly systemically, even though it can produce strong stimulatory and then depression on the cardiovascular system or on the GIT, but Carbachol is not commonly used systemically. Presently, it is used less commonly in the cases of glaucoma when Pylocarbine is ineffective, right? Methylcholine. Methylcholine is used when? To check the bronchial hyperreactivity. Is that right? Then in the end, we are left with Pylocarbine. What are the two important uses of Pylocarbine? Number one, in the mouth, and number two, in the eyes, for the eyes. For the eyes, we use it in open angle glaucoma because, right, ciliaris contraction, pull the trabecular meshwork and help in drainage. It can be used also in closed angle glaucoma where strong meiosis pulls the iris root away from the angle and open the angle, right? Secondly, in the eyes, it can be used to reverse the mydriasis produced by atropine. Thirdly, to break the adhesions between the lens and the iris, Pylocarbine can be used in alternation with, not combination, alternating use with the mydriatic drugs, right? In the end, Pylocarbine can also be used as a sialogogue. Sialogogue means producing agent which produces a lot of saliva, right? And this type of use is required in conditions of xerostomia when mouth is very dry, right? Xerostomia can be produced by irradiation of head and neck, right? Or it may be produced by autoimmune destruction of salivary glands like Sjogren's syndrome, in which lacrimal gland is also significantly destroyed. If there is some residual gland left there, we can stimulate that by the Pylocarbine and get some salivation, right? We can keep our mouth wet and we can also keep our eyes wet. Eyes may become very dry, we call it xerophthalmia. So having xerophthalmia or xerostomia is not a very pleasant feeling. Is that right? And class dismiss. Right, so we were studying about the cholinergic drugs, and let's recap a little. Last time we were talking about the drugs which are cholinergic drugs. They can be divided into, yes, two groups. They were direct acting and, yes, indirect acting. Very good. And indirect acting. Direct acting were those drugs which could directly stimulate the cholinergic receptors, right? And in that, the drugs which were working on muscarinic cholinergic receptors we discussed in last lecture into detail, right? Let me take a little assessment of you. There was a drug which direct acting cholinergic drug which could activate the bowels and bladders. What was that? Bethanycol. Okay. And Pylocarbine is used in narrow angle glaucoma or wide angle glaucoma? Both of them. Right. Now you can tell me that Bethanycol, right? Bethanycol has powerful muscarinic action or nicotinic action? Yes? Muscarinic action. Very good. And another question, that Pylocarbine increases secretions and it can be used to stimulate the saliva production, right? In which condition? Sjogren's syndrome and when there is xerostomia which may be due to irradiation to head and neck. That's great. So now we start our today's work. We are going to discuss indirectly acting cholinergic drugs. Now what are indirectly acting cholinergic drugs? These are those drugs which basically bind and inhibit cholinesterase enzymes. As I discussed last time, that if this is a cholinergic neuron, and if this neuron is releasing here acetylcholine is going to work on this tissue. Suppose this is a tissue, right, which may have ion channel receptors, which are nicotinic receptor for acetylcholine or 7-pass, G protein coupled receptors, which are serpentine receptors. Now, you remember that we discussed acetylcholine can work on nicotinic receptors or can work on muscarinic receptors, but very rapidly it is catabolized, right? And it is catabolized by an enzyme called, yes, acetylcholinesterase, right? This enzyme rapidly destroys acetylcholine. Now, our today's lecture is about those drugs which can actually bind with this enzyme. The drugs which can bind with acetylcholinesterase and the drugs which can inactivate the action of cholinesterase, a drug which has bound and it reduces the action of acetylcholinesterase. And if any drug binds with acetylcholinesterase and does not allow it to destroy the acetylcholine, then endogenously released acetylcholine half-life will increase and it will accumulate at the synapses, and its action on the nicotinic and muscarinic receptors will prolong and increase. So in a way, the drug which bind with acetylcholinesterase and inhibit them, they increase the concentration of acetylcholine in the synapses and indirectly they enhance the cholinergic action in our body. Is that right? So today's lecture is about anticholinesterases. Now anticholinesterases drugs, indirectly acting drugs or anticholinesterases, there are two types of the drugs. They are reversible inhibitors of acetylcholinesterases, and there are irreversible inhibitors of acetylcholinesterases, right? What I mean by this, there are some drugs, listen carefully, they bind with this enzyme, right? They bind with this enzyme, and enzyme keep on working on those drugs, but it takes a very long time that enzyme get rid of those drugs. Reversible drugs bind with the enzyme, but over many minutes and hours, those reversible drugs detach. So it means these reversible anticholinesterases keep the enzyme action inhibited for many minutes or even many hours. Is that right? But these irreversible anticholinesterases, once they bind with the anticholinesterases, right, gradually they so strongly bind that enzyme is never recovered. This is a very important thing. That reversible drug bind with the enzyme, but sooner or later they detach from enzyme, right? Or they set the enzyme free. But once the irreversible drug bind with the enzyme, it never let the enzyme free. It means enzyme activity is lost for, not forever, it is lost for many days and weeks until new enzymes are synthesized by the tissue. Because if you can say you are inhibiting these permanently, that what will happen? If patients survive, then tissues will produce more enzymes, right? So it is very important to understand that reversible enzymes, reversible drugs inhibit the enzyme for shorter duration, right? Irreversible drug block the enzyme or waste the enzyme activity for the life of the enzyme. But actually when new enzymes are synthesized by the tissue, then recovery will be there if patient have survived. Is that clear? Now, I will first start discussing the reversible drugs and then I will go to irreversible drugs. So we are talking about the cholinergic drugs, And cholinergic drugs are direct acting, which stimulate the receptors, and indirect acting, which inhibit the acetylcholinesterases and increase the concentration of endogenous acetylcholine by reducing the destruction of acetylcholine, right? Now, we start discussing one by one anticholinesterases, anticholinesterases. These are a group of drugs which are reversible. Later on we will talk about irreversible. Now, these reversible anticholinesterases, there are many drugs. One of them which I will discuss first of all, that is physostigmine. Physostigmine. Now, physostigmine is an alkaloid. It means it is derived from plant. This is number one thing, that it is alkaloid, and so it is derived from the plant. Secondly, this is tertiary amine. Its structure is tertiary amine. Now here I want to make it clear. In this group, some of the drugs are tertiary amines and some of them are quaternary amine. Do you think this thing has any importance? That if I say this drug is tertiary amine and this is quaternary amine, what is the real difference created by this system? Yes?
Blood-brain barrier.
Okay, very good, excellent. One of you is saying that these drugs will behave differently in regard to blood-brain barrier, right? Let me tell you, tertiary amine are less polar and quaternary amines are more polar. It means tertiary amines are more lipid soluble and quaternary amines are less lipid soluble. Again, let me tell you, the drugs which are tertiary amines, they are less polar and more lipid soluble. Drugs which are quaternary amine, they are more polar, more charged. They have more charges on the surface and they are less lipid soluble. Now, only this thing that, right, tells you a lot about it. For example, the drugs which are less polar, they will be able to absorb from GIT better, because less polar drugs or more lipid soluble drug will cross the biological membrane, lipid membranes more effectively. Because physostigmine is tertiary amine, right, and it is more lipid soluble. So what it will do, physostigmine, it will be able to absorb from the GIT effectively. It will be able to cross blood-brain barrier. Is that right? Physostigmine will be able to cross blood-brain barrier. Even physostigmine will have more action on the ganglia, because most of our ganglia are embedded in fat. And these are lipid soluble. They can enter into fat and have more action on the ganglia. Opposite to that, there is other drug which I will discuss later. For example, neostigmine. Neostigmine. Then I will talk about later pyridostigmine. I will also talk later about a drug which is called adrophonium. Now, why I put this name? Because I want you to have a clear concept. Physostigmine is tertiary amine and all others are quaternary amine, right? All these are quaternary amines. So it means this is less polar and more lipid soluble, and these are more polar and less lipid soluble. So it means physostigmine will be able to cross the blood-brain barrier and produce action in the central nervous system, and even can produce toxicity in the central nervous system. But neostigmine, pyridostigmine, adrophonium, they are more polar molecules. They cannot cross blood-brain barrier effectively, so they cannot produce CNS toxicity. Is that right? Am I clear? In the same way, if you compare physostigmine and neostigmine, right, it is more lipid soluble, it is less lipid soluble. Because physostigmine is more lipid soluble, it will dissolve into fats and reach up to the ganglion, so it will have stronger ganglionic stimulation. And neostigmine does not very effectively dissolve into fat, so it does not very effectively stimulate the ganglion. Am I clear now? No problem here. Another thing which you are supposed to know, that this is alkaloid, but this is synthetic drug. This is synthetic drug. This is synthetic drug. Right? This is derived from plant, and these three are synthetic drugs. Another difference which is very important to know, that first three of these, they are having carbamate group into them, and this one is alcohol group. Right? Now you may be thinking why it is so important to know a little detail. Let me tell you why. Let us suppose this is your enzyme. I'm going to show the action of different drugs on, yes, acetylcholinesterase. Now, look, adrophonium bind with the enzyme relatively loosely. Adrophonium bind with the enzyme relatively loosely and very rapidly detaches. Adrophonium, we can put it like this. This is the binding of adrophonium, right? Right. Now, adrophonium does not make a strong covalent bond. It does not make a strong covalent bond, and it rapidly dissociates. So its duration of action will be more or less? Less. Usually adrophonium work maybe 10 to 15 minutes, 10 to 20 minutes at the maximum, 10 to 20 minutes, adrophonium. But then there are other drugs like physostigmine, neostigmine. Physostigmine or neostigmine, they bind here, but they do make covalent bond. They make covalent bond. But these covalent bonds which are made by neostigmine or physostigmine, they are labile covalent bond. What are they? They are labile covalent bond. Labile covalent bond is actually a bond which can be eventually broken. Labile covalent bond is, there's a covalent bond which is a strong bond, but it is labile. It is not forever. Eventually it breaks down and drug goes away and enzyme can restart its function. Is that right? Now, it is very loosely bound. It is a little more tightly bound, right? So its duration of action will be more than adrophonium, right? Its duration of action is usually 30 minutes to 2 hours, or in some of these drugs up to 4 hours. These are the drugs which are carbamates. Listen, carbamate make labile covalent bond. Now what are carbamate? Carbamates are physostigmine, neostigmine, pyridostigmine, right? They make the labile covalent bond with the enzyme, right? So they, from half hour to few hours, they keep on inhibiting the enzyme. But when we come to adrophonium, it does not make covalent bond. Adrophonium bind very, very weakly. It makes a non-covalent bond. So it rapidly dissociates within few minutes. So its action is not more than 15 to 20 minutes. Then I told you another class of anticholinesterases is irreversible anticholinesterases, right? Irreversible anticholinesterases are really dangerous. Do you know any irreversible anticholinesterase? Irreversible anticholinesterases. Irreversible anticholinesterases are those drugs, or rather we should say toxic compound, which bind with this enzyme very, very strongly. They bind here very, very strongly. Right? They are making strong covalent bonds. They are making strong covalent bonds, irreversible anticholinesterases. And another thing, initially when they bind, they can be removed from the drug. But after few minutes, after passing of a little time, they so strongly react with the enzyme that you cannot remove it. Again, let me tell you. For example, this is the drug which is binding over here. It has a special alkyl group here. Alkyl group. When irreversible anticholinesterases bind with the enzyme, of course, enzyme is very, very sad. It's very sad. Rather, it is weeping. You know why? Because this is also sad but not weeping. And here, it is really tricky. It knows it will get out. Now listen. Adrophonium bind very loosely and within 10-15 minutes detaches, enzyme recovers. Cholinesterase activity recovers. Carbamates like neostigmine, physostigmine, pyridostigmine bind with covalent way, right? But this is labile covalent bond, not a stable covalent bond, and eventually they also detach, but their action of inhibition remain from half hour to few hours. Is that right? The real problem is irreversible anticholinesterases. Irreversible anticholinesterases are, can you tell me some name? Isofluorophate, isofluorophate, or ecothiopate, H. Or there is melathion, or there is another drug which is parathion. Now, isofluorophate or ecothiopate, or I think this H is not there. Ecothiopate, melathion, parathion and related compound, they are very nasty compound. They make very stable covalent bond with the acetylcholinesterase, right? So they really bind it strongly. And then another complication is there. Once they remain sticking to the enzyme for about 30 minutes or more, right, then this alkyl group detaches. Remember clearly. If alkyl group is still there, when enzyme is sticking with this drug or toxic compound, initially alkyl group is there. Actually, there are other drugs which can come and remove the inhibition. But once alkyl group is detached, it is impossible to remove the compound from there. Again, let me repeat it. These groups are having a special alkyl group. And this alkyl group, you understand it? CH2, CH3, CH3 like that, propyl or, okay. Alkyl group is there. In the beginning, when drug bind with the enzyme, right, alkyl group is still with the complex. Until alkyl group is there, we can bring some antidote which can remove this from there. That antidote is called pralidoxime. What is the name of that antidote? That is pralidoxime. What is the function of pralidoxime? It can remove this from here. It can remove this. Pralidoxime. Pralidoxime. Right? But after 30 minutes or so, this alkyl group automatically detaches. And if it detaches, do you think we can recover enzyme? Regenerate enzyme? No, enzyme is truly lost forever. This process of loss of alkyl group and then drug permanently inhibit the enzyme. This process is called aging. What is that? This process is called aging. Aging. Why this concept of aging is so important? Why I'm trying to stick or hammer in your mind? The reason being, if someone is accidentally or someone wanted to commit suicide by these drugs or homicidal attempt, if someone, these compounds have gone in his body and these enzymes are inhibited, if at initial time very rapidly you provide pralidoxin before the alkyl group is lost, before the aging has occurred, you may save the patient, right? But if due to some reason diagnosis could not be made in time, or due to any reason you have not given pralidoxin before the aging process and aging has been done, then pralidoxin cannot work as a very effective antidote. You must know such compounds are present in many insecticides. Have you heard of insecticide or pesticide poisoning? Right? They are present in many insecticides. We spray on the crops, right? These compounds are not only present in insecticides or pesticides. Unfortunately, scientists are working very hard to make more and more such compounds for military use. And the bad news is that recently they have made some compound which are irreversible anticholinesterases which can age in few seconds, which can undergo the aging process within few seconds. And if someone has been exposed to those nerve gases or nerve agents, is that right? What will happen? Very rapidly all the anticholinesterases in the body will be inhibited. And while most of the anticholinesterases are inhibited and permanently inhibited, what will happen? All the acetylcholine, which is normally, physiologically, endogenously produced, it will dangerously accumulate at the cholinergic sites. And there will be massive cholinergic outflow. And you can understand what will happen. So we were talking, if someone is exposed to irreversible anticholinesterases, right? What will happen to the patient? That all of the acetylcholinesterases will be inhibited, and endogenously produced acetylcholine will accumulate and produce very powerful cholinergic stimulation in the person's body, right? And that will produce signs and symptoms of what is this? Toxicity by these. Now there are 4 tissues or 4 levels at which acetylcholine accumulate and produces complications. Number 1, if some of these substances which can cross the blood-brain barrier, they go to the central nervous system and enzymes are inhibited in central nervous system, there will be very strong toxic accumulation of acetylcholine in central nervous system, and it may stimulate the central nervous system so powerfully that patient may develop convulsions, right? Seizures. Secondly, acetylcholine accumulate in the ganglia, sympathetic and parasympathetic ganglion, and there is powerful pathological stimulation of ganglia. Thirdly, acetylcholine accumulate at the neuroeffector site of parasympathetic nerve endings, postganglionic parasympathetic nerve ending, and all over the body there is very powerful muscarinic stimulation because at these sites there are muscarinic receptors. And last but not least is that there's a lot of accumulation of acetylcholine at neuromuscular junction, and these nicotinic receptors at neuromuscular junction, when they are very strongly stimulated for very long duration, right, what happens? They produce depolarizing nerve block and paralysis. Again, let me tell you that if this is your cholinergic nicotinic receptor, if it is overstimulated, you remember from previous lecture, if it's acetylcholine bind and detach, it will let the cations go in. But if acetylcholine is in very high concentration and remain attached with this ion channel for very long duration, ion channels will become dysfunctional and neuromuscular transmission will fail, and patient will develop paralysis, right? But not only patient develop paralysis and convulsions, patient also develop lot of clinical features related with the muscarinic cholinergic stimulation. For example, there will be massive sweating, there will be lacrimation, there will be, yes, salivation, right? Then as you go down, what else will be there? Bronchoconstriction, bradycardia, hypotension, right? Overstimulation of GIT, abdominal cramps, and there may be even diarrhea, there may be urination, right? So all generalized feature overstimulation of cholinergic system will produce its signs and symptoms in such patients. Is that right? The point is that when you manage such a patient, the point number one is that you should give atropine. Advantage of atropine is that atropine will block the muscarinic receptors. So all those clinical features which are, or problems which are produced due to overstimulation of muscarinic receptors, they will be abolished. Secondly, we should give some chemical antidote. The classical substance available is pralidoxime. Now pralidoxime, how it functions? Pralidoxime bind the, what is that? Organophosphorus compound. Irreversible, what is this? Irreversible anticholinesterase drug, right? And it binds and detaches that. But remember, pralidoxime is only effective when aging has not occurred. Aging has not occurred. It means when alkyl group is specially present with the organophosphate compounds. All these compounds are also called organophosphates. So if organophosphate are still having alkyl groups, right, and they have not gone under aging, then pralidoxime will remove the organophosphate from the enzyme and enzyme will be regenerated. But if aging has occurred, right, some significant time has passed and aging has occurred, it means now this drug has bound so strongly with the enzyme by losing its alkyl group. It has so strongly bound that even if some antidote like pralidoxime come, it cannot regenerate the enzyme. Am I clear? Another way to remember, okay, so this was some basic concept again. Very loosely binding, this is what? Acetylcholinesterase. Very loosely binding compound is adrophonium, right? It is very short acting. Then there is carbamates, right, which are like physostigmine, neostigmine, pyridostigmine. They bind and inhibit the enzyme for half hour to few hours, right? But organophosphate compounds or irreversible compounds, once they bind there, they're really inhibited for very long time, and after some time by losing the alkyl group, right, the drug organophosphate compound, right, binds so tightly that even pralidoxime cannot remove it, and that process is called aging. Is that right? Now let's come back to this discussion. We were talking about reversible anticholinesterases, and let's discuss first of all physostigmine. As compared to other, physostigmine is more lipid soluble, right? And why it is more lipid soluble? Because it is not quaternary. It is not quaternary amine. It is tertiary amine. It is less polar, more lipid soluble, so it can go to the central nervous system. Physostigmine can go to the central nervous system. Is that right? Now, what will be the actions of physostigmine? If someone is given physostigmine systemically, what will be the action? It's so easy to understand. All these sites, central nervous system stimulation will be there, ganglionic stimulation will be there. What is this? What is this? Neuroeffector sites at parasympathetic sites will be stimulated, and at neuromuscular junction, nicotinic cholinergic receptors will be stimulated. So we were talking about the therapeutic uses of physostigmine, right? Now physostigmine, where it can be used, number one, it can stimulate muscarinic receptors. It can stimulate muscarinic receptors, especially on the GIT and bladder, urinary bladder. So it can be used to stimulate the motility in gastrointestinal motility and urinary bladder motility, right? You remember there was another drug which could stimulate the bowel and bladder? Methylcholine, right? So physostigmine can also be used in the conditions where normally methylcholine is used. The difference in physostigmine and methylcholine is directly acting muscarinic stimulant, right? You remember I told you methylcholine could directly stimulate the muscarinic receptors on GIT and bladder, both activate the bowel and bladder. Actually, physostigmine can also stimulate the bowel and bladder. Indications are same. As you remember that postoperative abdominal distension due to paralysis of GIT, right? You can use physostigmine. Or if there is non-obstructive urinary retention, postoperative or postpartum, you can use physostigmine. Again remember, methylcholine and physostigmine both are used for this condition. The difference is methylcholine directly stimulates the muscarinic receptor, but your physostigmine actually does not stimulate the receptors. It actually inhibits the breakdown of acetylcholine, and then endogenous acetylcholine increases its action at cholinergic receptors, right? Secondly, physostigmine can be used in glaucoma also. You can understand why. If physostigmine is applied topically to the eye, to the cornea, it will lead to constriction of pupil. You can understand why? Because there is more acetylcholine accumulation there and contraction of ciliaris muscle. Is that right? Again, why? Because acetylcholine is accumulated there. Sometimes Pylocarbine and physostigmine are applied in combination. How? In some cases, in case of glaucoma, you can give Pylocarbine and physostigmine both. Why? Pylocarbine can directly stimulate the muscarinic receptors on sphincter pupillae and ciliaris, and physostigmine, by inhibiting the cholinesterases, increase the acetylcholine concentration on the sphincter pupillae and ciliaris muscle. Am I clear? There is no problem, right? You can understand, of course, when meiosis will be there, the base of the iris will be lifted away from the angle, and it is good in case of angle closure glaucoma. And when ciliaris contract, it produces a traction or pull on the trabecular system, trabecular meshwork at the angle, and that enhances the drainage of aqueous humor, and that is good in case of open angle glaucoma, right? Then another use of physostigmine is in those patients where due to some compound cholinergic activity is reduced. For example, there are some drugs which have anticholinergic activity. For example, if you have given me toxic dose of atropine, then what will happen? That my muscarinic receptors are pathologically blocked. And if you want to bring action on muscarinic receptors, you can give physostigmine, and physostigmine will go even to central nervous system as well as in the peripheral part of the body and increase the concentration of acetylcholine, right? And then acetylcholine can displace the atropine, and or even the presence of atropine, it may initiate some of the muscarinic action. You are understanding it? So it can be used in overdose of atropine. So in atropine toxicity, right? Atropine is a drug which blocks which receptors? Muscarinic receptors, right? And if someone has overdose toxicity of the atropine, you can give, what is this? Physostigmine, and it will increase the concentration of acetylcholine at the synapses, and at higher concentration of acetylcholine, there will be muscarinic action restored, right? Even there are some other drugs like phenothiazines. These are the drugs which are used as antipsychotic drugs. These drugs also have anticholinergic activity. If someone tried to commit suicide by taking a lot of phenothiazines, right? So there will be powerful anticholinergic activity. Phenothiazines block the muscarinic receptors. Atropine block the muscarinic receptors, right? So it means that atropine has anticholinergic activity. Phenothiazines do have anticholinergic activity. So to restore cholinergic activity in these conditions, you can give physostigmine. Am I clear? Why you are looking lost? You are understanding me? Okay, that's good. And then tricyclic antidepressants. Tricyclic antidepressant. This group of drug also have anticholinergic activity, right? Tricyclic antidepressants can also bind with the cholinergic receptors and block. And if someone tried to commit suicide by taking a toxic dose of tricyclic antidepressants, one of the part of the management is giving the physostigmine, right? What physostigmine will do? It will increase the acetylcholine at synapses by inhibiting the acetylcholine esterases, so that there is effective, what is that? There is effective activity on the cholinergic receptor, right? So what are the main action of physostigmine? Number one, physostigmine can be used to mobilize the GIT or urinary bladder like methylcholine. It can be used in glaucoma patient, right, along with the Pylocarbine or independently. It can be used in those toxic state where there is too much anticholinergic activity in the body. Then we can use physostigmine to upgrade our cholinergic activity in the body. Am I clear? And what could be the side effects of physostigmine? Side effects of physostigmine, number one is central nervous system overstimulation and eventually convulsions, right? Secondly, paralysis. If physostigmine is given in toxic doses, then so much acetylcholine will be at neuromuscular junction that overstimulation of nicotinic receptor lead to dysfunction of the receptors and neuromuscular transmission fail, and that will lead to, what is that? Paralysis, right? And then of course, if there is too much cholinergic activity on the cardiovascular system, that may lead to collapse of cardiovascular system. Am I clear? So we have to use it judiciously. After discussing the Pylocarbine, now I will talk about neostigmine. I told you Pylocarbine is a natural compound, it's an alkaloid, but neostigmine is synthetic. Pylocarbine was tertiary amine and neostigmine is quaternary. So neostigmine is more polar compound, right? But both of them are carbamates. They are having carbamate groups. Now, neostigmine. Neostigmine means no CNS, rather we should remember neostigmine, not to CNS, right? Because it's a very important concept. Physostigmine goes to central nervous system, neostigmine does not. For example, if there is atropine toxicity, physostigmine is better because atropine also produces central nervous system toxicity. But neostigmine cannot go to central nervous system. Am I clear? Is that right? So what I am saying that one of the major functional difference between physostigmine and neostigmine is that physostigmine enters the central nervous system, neostigmine does not. No to CNS. Number one thing. Number two, because neostigmine is less lipid soluble, it dissolves less into fat, and most of our autonomic ganglia are embedded in fat. So neostigmine action on the autonomic ganglia and parasympathetic neuroeffector site is relatively less. It is not absent, but as compared to physostigmine, it is less. So ganglionic stimulation and stimulation at neuroeffector, ganglionic stimulation and stimulation at parasympathetic neuroeffector site is relatively less in neostigmine as compared to physostigmine. Does it make a sense? Because it is less lipid soluble. Is that right? Another thing which is very important, that the best action of neostigmine is at the neuromuscular junction. And at the neuromuscular junction, action of neostigmine is even better than physostigmine. Why? The recent research is telling us neostigmine also work directly on the nicotinic muscular receptors, cholinergic receptors. So it means that in case of neuromuscular junction, right, not only acetylcholine esterases will be inhibited and acetylcholine concentration will be increased, but neostigmine can directly stimulate the cholinergic receptor at the neuromuscular junction. So it means to stimulate the neuromuscular junction, neostigmine is a better drug as compared to physostigmine. Did you understand it? To stimulate the neuromuscular junctions, neostigmine is better drug as compared to the physostigmine. Is that right? But now, what are the uses of neostigmine? Before really I go into detail of the uses of neostigmine, I want to give you a concept of myasthenia gravis, where it is used very commonly, right? What is a disease called myasthenia gravis? So let me tell you, let's suppose this is a nerve ending. This is alpha motor neuron and it is releasing here acetylcholine, and here is neuromuscular junction. And what is this thing? This is the receptor, nicotinic receptor, where acetylcholine will bind. And here is your friend which loves to destroy acetylcholine esterase. Is that right? Now what happened? At neuromuscular junction there are many nicotinic channels. There is a disease called myasthenia gravis. Myasthenia means weakness. Gravis means very grave, very serious weakness. Gravis. Myasthenia gravis, what really happens that unfortunately autoantibodies are formed. It's an autoimmune disease. Autoantibodies are formed against the cholinergic nicotinic receptors on neuromuscular junction. So what really happens that autoantibodies bind with these cholinergic nicotinic receptors. When these ion channels are bound with the antibodies, antibody and ion channel complex undergoes internalization. When it is internalized at the neuromuscular junction, the number of ion channel will be more or less. Cholinergic ion channel will be less nicotinic. Secondly, some of them will be internalized and others channels, even if they are not internalized, because they are having the antibody on them, can acetylcholine effectively work there? No. So what really happens that at the neuromuscular junction, antibodies bind with the cholinergic nicotinic ion channels, right, lead to internalization of ion channels or inhibition of ion channels, and then acetylcholine cannot effectively work at the postsynaptic membrane, cannot produce enough end plate potentials, and muscle cannot be contracted. Because if end plate potentials are not produced enough, then propagating action potential cannot be produced and neuromuscular transmission fails and muscles will be weak. You understand it? It reminds me an old story, I think in 1930s. There was a medical student, and this is a true story. There was a medical student and he was having his high school sweetheart. They really loved each other, and those were not the days when you just go and sleep around, right? So they talk to each other, they will eventually marry, right? The passion of the boy is to dance a lot, and his girlfriend was really very good dancer. But something happened to her. Gradually, she stopped taking interest in dancing, and she started saying she feels a lot of fatigue. And this condition becomes so progressive, it becomes so progressive that even she finds it difficult to walk. She will walk few steps and then she will feel tired. You can understand under these circumstances the engagement was under risk. But he was not like most of the boys. That medical student, I don't know how, just by chance, he started trying some drugs on her, on his girlfriend. And one of the drug which by chance was applied was physostigmine, by chance. He just gave it to his girlfriend. He was trying to give different types of cocktails made of different drugs. One of the cocktails was having physostigmine, and you can understand. She was drinking physostigmine and dancing a lot that night. And that was when first time we came to know that anticholinergic drug, anticholinestrases can be used in myasthenia gravis. Right? At that time it was physostigmine. Presently we don't use physostigmine for that purpose. Neostigmine is superior. Because if someone has myasthenia gravis, you give physostigmine, it will go to central nervous system and make some troubles. Neostigmine will work mainly on the peripheral part. But let's come back and see what is the problem in myasthenia gravis. The autoantibodies are destroying and inhibiting what? Nicotinic receptors. And then muscles become progressively weak. In this condition, especially, more a person work, physical work, more tired he feels. Is that right? Now, how our drugs work? Actually, neostigmine will come and inhibit what is this? And acetylcholinesterase. When neostigmine will inhibit the acetylcholinesterases, the concentration of acetylcholine will be more. Then more acetylcholine will be working on less receptors. But less receptors will throw more cations in and successfully produce the propagated action potential, and power of the muscles will come back. Is that right? So this is myasthenia gravis, in which neostigmine is being used presently very effectively, right? You understand the whole mechanism? Now, another condition is there, and there also a person has myasthenic weakness, but mechanism is different. I'm going to explain a second patient. In this patient, at neuromuscular junction, nicotinic receptors are normal. Post-junctional membrane is normal. In myasthenia gravis, problem was at the post-junctional membrane. The receptors were having antibodies and they were internalized and they were inhibited. Acetylcholine was perfectly okay, and in myasthenia gravis, problem was with the post-junctional membrane, pre-junctional membrane was final. Okay. Here, there is another disease in which the calcium channels here, in the nerve endings there were calcium channels. Unfortunately, patient has developed autoantibodies against the calcium channels which are present on the nerve endings. So if these calcium channels are blocked with the antibodies or inhibited by the antibodies, then the action potentials, when it will come, they will produce relatively less calcium influx, because calcium channels, functional calcium channels which are available are less. So there will be less calcium going in, so naturally release of acetylcholine will be less. So what really happens here, that in these patients acetylcholine release is very less. Acetylcholine is very less. In these patients acetylcholine release was normal. Now when acetylcholine release is less, again stimulation of the post-junctional membrane will be less and muscles will develop weakness. So both of them are myasthenic syndromes. This is myasthenia gravis. What is the name of this condition? This is called a very funny name. Let me tell you, let's imagine a situation. In these two conditions, there is some difference. I have not told the name, I will tell you later. In myasthenia gravis, post-junctional membrane has autoimmunity attack. In this condition, pre-junctional membrane has a problem, right? This is one thing. Here muscles are weak, there also muscles are weak, but there is one difference. Here, as person physically work more and more, he feels progressively worsening weakness. Here person feels weak in the beginning, but with willpower, if he work a little, he will gradually feel better. Let me tell you a condition, that let's suppose you invite these two patients at your home on the dinner. This is patient number 1 with myasthenia gravis, and this is the patient number 2 with another problem. And they are having some weakness. You put very good cooked lamb on the table. Lamb, L-A-M-B, lamb? Okay, you put the lamb for both of them. You are expecting that both of them are very slow. Is that right? But when you start the dinner, in the beginning this will be working relatively better. But progressively, this person will become very tired. So what will happen? He start eating better and you feel he is going to take all the lamb, but he will not. In the end, he will be just looking to the lamb but cannot move his. You understand it? And look at that person. In that person, he will start in the beginning very slowly, very, very slowly. Why? Because he is bringing action potential, but little calcium is going in, so little neurotransmission. He moves very slowly to the lamb. But as time passes by, he is bringing more and more action potential, then calcium start accumulating, and eventually significantly more calcium start accumulating, and acetylcholine release become better. And eventually this person will keep on eating the lamb. So this person start better and eventually become very poor performer in eating. This person start poor but eventually become better. You understand why he become better? Why? Because with repeated action potential, he will accumulate calcium in the nerve ending and become more effective in releasing acetylcholine. Is that right? So eventually this person will eat up the lamb. That is why probably this disease is called, what is the name of this disease? Eaton-Lambert syndrome. Eaton-Lambert syndrome. Is that clear? So we can have myasthenia gravis as a muscle weakness. We may have Eaton-Lambert syndrome patient with muscle weakness. Now let's compare and contrast. In myasthenia gravis, okay, first few things common. This patient has muscle weakness and this patient has also muscle weakness. This is common. Here is autoimmunity against the neurotransmission system. Here is also autoimmunity against the neurotransmission system. Now we come to the differences. Here autoimmunity is against the postsynaptic or postjunctional membrane nicotinic channels. Calcium channels are okay. Presynaptic membrane is okay. In this case, postsynaptic membrane is okay. Problem is with the presynaptic nerve ending and calcium channels are having autoimmunity against it. Is that right? Another difference is that in myasthenia gravis, patients start very poorly, but while performing, he becomes extremely poor. Right? He starts eating the lamb very slowly and very soon he stops. This person starts eating the lamb slowly, but eventually it becomes little fast. Is that right? So lamb is eaten by him, Eaton-Lambert syndrome. Am I clear? The point which I want to highlight, neostigmine can work on both cases. When neostigmine is given in myasthenia gravis patient, acetylcholine esterase is inhibited, right? Acetylcholine accumulate in higher concentration and work on the lesser number of receptors, but higher concentration of acetylcholine working on lesser number of receptors may give enough stimulation. But in Eaton-Lambert syndrome, when you give, what is that? Acetylcholine esterase, if it is inhibited by neostigmine, then what happens? Even though in Eaton-Lambert syndrome, acetylcholine is released in lesser amount, but because we have reduced the catabolism of acetylcholine, it will accumulate into normal concentration, and normal concentration is enough to stimulate the postsynaptic membrane which is healthy. Is that right? Another third condition where we can use this drug is in toxicity of tubocurarine. You know tubocurarine? This is suppose another muscle, and here is these channels. What are these channels? Cholinergic nicotinic channels. And here is your friend. Who is that? Acetylcholine esterase, and acetylcholine is coming here, but a tubocurarine may be blocking some of these channels. Tubocurarine. Now what happens in patient who has been exposed to tubocurarine and muscles are very weak or paralyzed, one way to rapidly activate the muscle is give neostigmine. If you give neostigmine or related compound, it will inhibit, what is that? It will inhibit acetylcholine esterase, and acetylcholine concentration will become very high, and it will competitively displace the tubocurarine and overactivate the remaining channels, and person's muscle will start working. Am I clear? So we have talked about 3 types of muscle weakness: myasthenia gravis muscle weakness, Eaton-Lambert syndrome muscle weakness, and muscle weakness resulting due to exposure to tubocurarine. In all these 3 conditions, neostigmine can work by increasing the concentration of acetylcholine at the neuromuscular junction. And last but not the least, I told you in the beginning, neostigmine is having a little activity to directly stimulate the channels also at neuromuscular junction. Is that right? So neostigmine has 2. Number 1, it inhibits the acetylcholine esterases. Number 2, it can directly stimulate the receptor. So neostigmine is a strong indirect cholinergic drug, but it is also a weak directly acting nicotinic stimulant, nicotinic channel at muscle stimulant. Right? Any question here? There's no question. Can you tell me that there is any other use of neostigmine? Can you tell me some other use of neostigmine? Why don't you tell me that neostigmine can also be used to move the bowel and bladder, because it also increases acetylcholine at muscarinic neuroeffector sites. So to stimulate the bowel and bladder, number 1, you had directly acting cholinergic drug, which was Methylcholine. Number 2, indirectly acting drugs, right, and in which you can talk about physostigmine and neostigmine. Is that clear? So if there is atonic urinary bladder, or if there is paralytic ileus, you can use the physostigmine or neostigmine. But when we are going to stimulate the neuromuscular junction, the neostigmine is preferable over physostigmine. Am I clear? Any question up to there? And what are the side effects of neostigmine? Very simple. Generalized overstimulation of cholinergic system. If there is neostigmine toxicity, what will happen? There will be overactivity of acetylcholine all over the body except central nervous system. Right? So it means physostigmine toxicity is more dangerous because it produces cholinergic crisis in the central nervous system also. But neostigmine produces cholinergic crisis only in the peripheral tissue, not in the central nervous system. Am I clear? Now we come to another drug, pyridostigmine. Pyridostigmine and its friends. This P is very important. You know many things. P for what? Pyridostigmine and another drug which is related with that, and that drug is, yes, pyridostigmine, and it has some other drugs in association with it which are similar. Ambinomium. I don't know from where they find this name. Ambinomium. This P stands for what? P stands for what? P stands for prolonged, not for other things. P stands for prolonged. Pyridostigmine has a prolonged duration of action. Look, physostigmine is up to 2-hour action. Neostigmine is up to 2-hour action. Pyridostigmine may work up to 4 or 5 hours or 6 hours. It will keep on inhibiting the enzyme. And ambinomium may inhibit the enzyme for 4 to 8 hours. Now what does it mean? That these compounds are, even though functionally similar as physostigmine and neostigmine, but pyridostigmine has prolonged duration of action, and its related compound ambinomium is also prolonged duration of action. Due to that reason, these drugs like pyridostigmine are used more commonly in the chronic treatment of myasthenia gravis. Because in case of neostigmine, because its duration of action is short, you have to give more frequent tablets. But in case of pyridostigmine, you have to give less frequent tablets. Am I clear? So this is enough to know. Remaining things are same. Pyridostigmine is synthetic. It is going to inhibit the acetylcholine esterases, right? And it will increase the transmission at neuromuscular junction in case of myasthenia gravis, even in Eaton-Lambert syndrome, right? But the most important thing as compared to neostigmine is that it is longer duration. Let's come back. Remember, learn the physostigmine well, then remember neostigmine is different from physostigmine because it cannot go to central nervous system. Pyridostigmine also does not go to central nervous system. But as compared to neostigmine, pyridostigmine has a very big P. P stands here for prolonged action. Is that right? Now we come to the adrophonium. Adrophonium is very phony. What is the meaning of phony? Not funny, phony. Phony personality. Fake personality. Yeah, adrophonium like to be these drugs, but actually it really goes and bind with the receptor, bind with the enzyme, but enzyme will kick it away within 5 to 10 minutes. So its action is phony. Do you think phony personalities are important in life? No, they add some diversity in our culture. Don't underestimate everyone. If everyone is as serious as you are and I am, I don't think world will be a place where people will enjoy phony personalities, right? So, what I'm saying, adrophonium, because it is a phony drug. Why it is phony drug? It's a fake drug. It tried to be inhibitor of acetylcholine esterase, but the trial is successful only for few minutes, 5 to 10 or 10 to 20 minutes at the max, 20 minutes. And it is important. Should I tell you why it is so important? In some conditions, even it is superior to neostigmine, pyridostigmine. There are some conditions where we need our phony friends. You cannot take everywhere your serious friends. Is that true or not? There are some situations where you go with your phony friends, right? Let's see our phony drug, adrophonium. What is the importance of it? Let me give you a situation. If a person comes to you, listen. If a person comes to you and he has strong muscle weakness and you are suspecting myasthenia gravis, for example, I come to you and you are my physician and I complain of all those things that muscles are very weak and I do a little thing and I feel very tired, and for one or the other reason you suspect I may be having myasthenia gravis. One of the way to check that to diagnose the myasthenia gravis is, one of the ways that just give me a trial of anticholine esterase drug. If you give me anticholine esterase drug and after the drug my power increases, it is a good pointer that I am having myasthenia gravis. You are understanding? For example, if your wife makes you very depressed and you are very fatigued, then neostigmine will not make you powerful. But if you are really having myasthenia gravis and it's first time case and you want to diagnose it, one of the ways, just give a trial of the anticholine esterase, right? And anticholine esterases will inhibit the, you know the remaining story, inhibit the enzyme, increase the concentration of acetylcholine, and even if postsynaptic or at neuromuscular junction, even if nicotinic receptors are less, accumulated acetylcholine will do some transmission and immediately there will be improvement in power. There are many ways to do it. One of the way to do that, before giving the drug systemically, you ask the patient to do some hand grips. You see how many hand grips he can do it and when he feels very tired. And then you give it and you see how good he becomes after that. Compare and contrast the physical performance and power of muscles before and after the drug administration. Now another question. If you are using, for example, long-acting, relatively long-acting drugs for the diagnosis, and if patient is not having myasthenia syndrome, for example, I am not having myasthenia syndrome, but I am having weakness so due to some other reason, and you inject with this or that, and do you think my muscle power will increase? No. And then you give another injection, still muscle power not, but what will happen? I will start doing salivation, lacrimation, diarrhea, urination, abdominal cramps, bronchospasm, and if you have done something like this, CNS stimulation, do you think it's a good thing? And if it is pyridostigmine, it will work for 6 hours. Do you think? So everywhere, it's not a serious issue. Somewhere phony is good. Adrophonium is wonderful in these circumstances. Why? A patient comes complaining of the weakness. You rule out other causes. You are strongly suspecting myasthenia gravis. Inject the first, take some, for example, ask him to do the blinking. And when he becomes very tired, these patients start the blinking. Initially they are rapid, then they become slow, then they are unable to blink. They start looking like this. Then you give the injection, they become very rapid like this. It's immediate diagnosis of myasthenia gravis. Or another way is, the patient happened to be a, okay, I will not go into that example. Okay, they ask the patient to show some power by the hand grip, right? And you see after how many events, patient become very, tired. For example, after doing 3 times, he refused to do more. You give the injection of adrophonium, he do it 30 times. What does it mean? Myasthenia gravis. Right? But if patient is not having myasthenia gravis and he develops some cholinergic overflow, it will be only for 10 minutes or 20 minutes, not for 6 hours. You understand it? So do you think adrophonium is a superior drug or not for the diagnosis of myasthenia gravis as compared to others? So this is one very important use of adrophonium. It's coming with the name of tensilon. Tensilon, we call it tensilon test. That we inject the adrophonium to a person. Is that right? This is one use of adrophonium, that you do a tensilon test. Tensilon is the name by which the adrophonium is available in the market, right? Am I clear? Then there is one more use of this phony drug, adrophonium. Let me tell you, in some very confusing situations, again adrophonium may help you. Is that right? Let's see. Let us suppose you are having 2 patients with myasthenia gravis. You are having 2 patients with the myasthenia gravis, and one fine morning, both patients come to your clinic, they are under your treatment, right? And you know what is the basic problem in myasthenia gravis patient? These channels are, yes, these nicotinic channels are having antibodies against them. Is that right? Now, of course, antibodies are there and channels are not available for full function. This is patient number 1 and this is patient number 2, neurotransmission system. Right? You are managing them. You are treating these patients by what? What is this? Yes. Cholinesterase. And let's suppose you are treating them, these patients, by neostigmine. Right? Now listen carefully. Previously, when you adjusted the doses of your neostigmine with them or pyridostigmine, they were physically performing well. But today morning, both of them come back to you and they are again very weak. You ask them, are you taking neostigmine? They say, yes, we are taking neostigmine. But still they are very, very weak. What could be the reason? There are 2 reasons. Actually, autoimmune response against these receptors fluctuate. So you are understanding it? Autoantibodies concentration against these channels fluctuates. Right? Sometimes they are very high in concentration, sometimes less. They are not stable autoimmune reaction. Let us suppose this person, antibody concentration has become very high. Now he was taking his previously prescribed dose, but because autoimmune attack has flared up, right? So now the acetylcholine is, whatever is coming and whatever drug you are doing is not enough to activate the muscles. So he is having weakness. You are understanding me? Now in this case, you need to increase the dose or decrease the dose of anticholinesterase. Yes, you will increase the dose or decrease the dose? We will increase the dose. This is a case where we need to increase the dose, because this is basically, you can say, under treatment. Under present circumstances, when immune response against these channels has become flared up, right, it has been increased, so the previously prescribed neostigmine or pyridostigmine is not enough, right, to relieve the patient from symptoms of weakness, because more channels are blocked by the antibodies and very little channels are available. So we need to, we can say this is myasthenic crisis. This crisis in the patient life will be called which crisis? Myasthenia gravis has been aggravated. Myasthenic crisis. Now imagine the other person. This person has come to you, he is having myasthenic crisis, right, and he needs to increase the dose or decrease the dose? Increase the dose of anticholinergics. Now we come to the patient number 2. He was lucky. Why he was lucky? His immune system had reduction in the intensity of attack. So it is producing these days less antibodies. Because in this patient, autoimmune attack against the neuromuscular junction has been less, so most of the receptor have recovered. Now whatever previously prescribed dose is, that is overdose for this person. Why? Because acetylcholine, which is accumulating here, it is working on more receptors as compared to the previous time. And when it is working too much, it produces what? Overstimulation of the receptors and make them dysfunctional and muscles become paralyzed. And he is also having weakness. But this is called cholinergic crisis. What it is called? Cholinergic. So, you should have a very clear concept that patient who have myasthenia gravis, if they are on the treatment and again they develop weakness, it may be due to myasthenic crisis, that underlying disease has exacerbated, or it may be cholinergic crisis because underlying disease has gone. So, we were talking about myasthenic crisis and cholinergic crisis. In both cases, patient comes with muscular weakness. But in myasthenic crisis, because antibody concentration and immune attack against the receptors, nicotinic receptor has increased, right? So due to that reason, there is weakness. And in these cases, that we need to increase the dose of anticholinergics. Opposite to that, in cholinergic crisis, probably either patient has taken overdose of the drug or underlying disease process has been suppressed, right, or has been less active and more channels are available. Due to that reason, the acetylcholine is overworking, and due to cholinergic crisis, muscles are again showing weakness. I told you, when these receptors are understimulated, muscle become weak. When they are overstimulated, still muscle become weak. Now, in these cases, if you are really confused and you are not sure which patient has myasthenic crisis and which patient has cholinergic crisis, because patient don't have it written here and they don't have these diagrams on their faces. So how to know that patient who was previously diagnosed as myasthenia gravis patient, who has been stabilized on a specific drug with a specific dose and suddenly has developed weakness, is this weakness due to myasthenic crisis or is it due to cholinergic crisis? Answer is your phony friend will come to help. Adrophonium. You just inject adrophonium to both of them. If myasthenia crisis is the underlying problem, you inject the adrophonium, right? It will suddenly further inhibit the enzymes, acetylcholine will rapidly go up and muscle will start working better. So if patient power improve after adrophonium, right, it was which crisis? Myasthenic crisis. And if after the adrophonium, already acetylcholine was excessive, it become far more excessive, and whatever little power he had, he developed worsening of the signs and symptoms. Then it was what? Cholinergic crisis. Of course, cholinergic crises are made worse by hydrophonium, but only for 10 minutes or 15 minutes. Is that right? Am I clear? Of course, you will be having antidotes with you, but the thing is that because hydrophonium is short duration drug, it can be used to differentiate the myasthenic crisis from the cholinergic crisis. So now listen carefully. If I am a patient who is on the diagnosed patient of the myasthenia gravis and I am on the suppose neostigmine, previously I was well stabilized and from last 2-3 days I have developed very serious weakness again. And you are really not sure, am I having myasthenic crisis or cholinergic crisis? You will do tensilon test. You inject the hydrophonium and see. If my power improves, then it means that I am under which crisis? Myasthenic crisis, and you have to increase the dose of neostigmine. But if after the tensilon my power further decreases, then it means that I was under cholinergic crisis and my dose of neostigmine need to be decreased. Am I clear? So this phony friend, hydrophonium, help in two things. Number one, at initial diagnosis of myasthenia gravis. Secondly, patients of myasthenia gravis in the treatment, when again they develop weakness during the course of the treatment, hydrophonium helps you to differentiate the myasthenic crisis from cholinergic crisis. Is that right? Now, again let's go back. Physostigmine, alkaloid, tertiary amine can go to the central nervous system. Neostigmine, yes, quaternary compound does not go to central nervous system, more effective at neuromuscular junction, right? Then pyridostigmine, long-acting anticholinesterase of the same class, carbamate. And there is another compound, what is that? Yes, ambinomium. You can use pyridostigmine or ambinomium. Is that right? Any one of these, they have longer duration of action. And in the end, don't forget your phony friend, hydrophonium, that it can help you in the initial diagnosis of myasthenia gravis, as well as it can help you to differentiate the myasthenic crisis from crisis. Now last but not the least, there are some drugs which can go to the central nervous system and increase cholinergic activity there, right, but don't act much on the periphery. They are used in the treatment of Alzheimer's disease. You know, in Alzheimer's disease, there is deficiency of cholinergic system in the central nervous system. Do you know Alzheimer's disease? Yes. Alzheimer's disease. Now, especially there is a nucleus of Maynard, right? It provides a lot of cholinergic stimulation to the cortex, right? This is degenerated and cholinergic activity in cerebral cortex become less, and that reduces the patient's cognitive function, patient ability to learn and patient's ability to remember the things. Is that right in Alzheimer's disease? Now they are trying some drug which can go into central nervous system and inhibit the cholinesterases, especially the cholinesterases here, and slightly increase remaining activity of the remaining cholinergic system, right? The drug which the first drug which they started using was tacrine. Is that right? And then now they are not using it because tacrine produces strong hepatotoxicity, right? The other drugs now which are available, they are donizepam, second drug, first was tacrine, and third drug which is available, rivastigmine, and one more is galantamine, galantamine, right? So these drugs are commonly used in patients with Alzheimer's disease, right? And they don't reduce the progression of the disease, but they believe at least there is some symptomatic relief. Any question here? Yes, is there any question? There's no question? Okay, another thing. When there is severe cholinergic crisis, for example, severe cholinergic crisis may come due to any drug toxicity which is directly acting cholinergic drug or toxicity of indirectly acting cholinergic drug. Or severe toxicity classically occurs by those anticholinesterases which are irreversible. As I told you, isoflurofate or ecothiophate or malathion or parathion, I told you they are inhibiting irreversibly they inhibit what? Anticholinesterases and can produce very severe toxic symptoms which are due to very strong overflow of cholinergic activity in the body. So overflow of cholinergic activity can be remembered by dumbbells. Do you know dumbbells? Dumbbells. What are the spellings of dumbbells? Yes. L, then again another L. Wow, it's too much L. And how many S?
2 S's.
2 S? Then L should be 1, my friend. I don't know why you are interested in 2 S. L. 2 S, okay. Dumbbells. Dumbbells stand for what? D for? Diarrhea. Okay, let me change the... Right. U for? Yes. Urination. M for? Meiosis. Without dumbbells, you can even memorize, as I told you, that there will be severe sweating, CNS stimulation by cholinergic activity, there will be sweating, there will be lacrimation, there will be meiosis, there will be salivation, there will be abdominal cramps and diarrhea and urination, bradycardia, bronchospasticity, excitation of the muscles. Is that right? But let's come by dumbbells if you cannot remember by that way. B for bradycardia, bronchospasm, bronchospasm, and then B for, yes, bradycardia. I think you people have done some specialization in remembering this. E for excitation of CNS and muscles. L for lacrimation. S for salivation and sweating. Sweating and salivation. This is very important to remember, that what happens to a person when he has cholinergic crisis, right? Again, one way is to remember from the dumbbells. D for diarrhea, U for urination, M for meiosis, B for bronchospasm, another B for bradycardia, right? E for excitation of central nervous system and skeletal muscles, L for lacrimation, S for sweating, and S for salivation. Or another way is to work from the top of the body to down. Excessive cholinergic activity, central nervous system, overstimulation and excitation. Then too much sweating, too much lacrimation, meiosis, then salivation, and with that of course abdominal cramps and diarrhea, GIT. Then you come down, then bronchospasticity, then there is bradycardia. Is that right? Then you come further down, yes, urination, whatever is left now, muscular weakness, right? So this is one way to remember or another way to remember, but you must know what happens to a person when he has cholinergic crisis. Any question? Okay, class dismissed.